who cannot be on the call tonight due to clinical responsibilities. These are not published in a general sense in any way. If you have any problem participating with a recorded session, you're invited to leave now, but your staying with us implies your permission to participate in the program as it is. This program tonight will provide 1.5 hours of Category 1 Physician AMA CME credit and 1.5 hours of Virginia Nurses Association CE credits. The Medical Society of Virginia is a member of the Southern States CME Collaborative, which has accredited us to provide Category 1 CME credit. This program is accredited by the Virginia Nurses Association, Nurses Credentialing Centers Commission on Accreditation for Nursing CEs. The program was developed to promote desirable physician attributes, including our providing patient-centered care, employing evidence-based medicine in our practices, and always expanding medical knowledge. Two of our speakers do have commercial relationships that they disclose to us that have been in place within the past 24 months. This first one is Dr. Shaw, our first speaker's relationships. I'll give you a moment to look at that. These are relationships that are described by the category of type, research grant, advisory board, speaker bureau, consultant, etc. And in order to manage those relationships, accreditation requirements require a mitigation plan. The plan that Dr. Shaw has agreed to is one in which he has attested that he will only be making evidence-based medicine recommendations for clinical care that are free of commercial bias and come from peer-reviewed literature and or consensus guidelines. In addition, he's provided his slides to the CME office for commercial bias prior to the program, and he has no such bias in his slide deck. Similarly, Dr. Hashim disclosed these relationships to four companies over the past 2 years. He likewise has attested that he will follow evidence-based medicine free of any commercial bias coming from the peer-reviewed literature and or consensus-driven guidelines for any recommendations he made. He also has submitted his slides for review, which was done earlier this week, and his slides have no commercial bias. That being said, myself and the members of the Sovah Health CME Committee have nothing to disclose as far as commercial relationships. This program tonight does not have any commercial support for its presentation. This program, as is the case for all of our CME programs at Sovah Health, are supported by the Ralph Landis Medical Education Fund that resides at the Danville Community College Educational Foundation. Dr. Landis, who was the founder of the local urological clinic upon his retirement, donated a significant amount of money to initially the hospital, which the money was then later moved to the Educational Foundation. Dr. Landis indicated these funds to be used for medical education in this area of the Commonwealth. And indeed, that fund supports not only physician education in our communities, but also that of nursing, EMTs, dentists, dental hygienists, and other related healthcare professionals. You will receive probably this evening or in the morning at the latest a CME evaluation form. We have someone that needs to be muted.
Quiet.
Mary, thank you.
I want to make sure.
Thank you. The CME evaluation form contains several questions, but draw your attention to question, I think, number 4, which asks what changes may you be making after the program in your own practice. And this is for everyone, not just the physicians. Each of us in our own scope of practice within a healthcare profession that we are practicing in has the potential to change how they approach their patients' care. So take a few minutes when you get the eval form and please answer that if you would. I'll also point out that you'll be asked for on the evaluation form to re-enter your name and email address. This is very important because the name you provide us, we still need to get, I think Dr. Shohan or someone else muted. We've got several open mics. I see 3 open mics. I don't know if you can do that or not, Mary. But we remind you when you fill out the evaluation form to please put in your full name. Please don't give us any nicknames or cute names. Likewise, if you're sharing the log on tonight with another person, there's 2 of you listening, which we welcome you to do so. Please let Mary Kent or myself know so we can be sure that everyone gets credit for their attendance. Please know that an evaluation form does not have to be completed in order for you to receive a CME certificate. That's totally up to you. And if you are not going to do a certificate, Mary will be in touch with you about that. For the medical residents on the call tonight, please know that you do not need to track your CME certificates for your participation. Your program coordinators, Dara Johnson, Lori Galvez, will track those for you, and they are aware of your attendance this evening. The CME certificates are emailed out once eval forms come back in an automated format. We also like to let everyone know if there are any physicians on the call who've not been on the call for the past several months that we do participate in the Program and Activity Reporting System nicknamed PARS, which is a national tracking system for the American Medical Association's accredited CME, of which we are a part. Passport tracks your participation in a national website. This is linked to several of the, if you will, certifying boards, and the certifying boards document your CME participation based on it being entered into Passport. If you've not given permission for us to share your information with Passport previously, at the bottom of the eval form, you'll find a request for, again, your name, your birth day and month, not the year, and the state in which you were licensed. If you have any questions about that, please reach out to me or Mary, and we'll be happy to explain it further. Just to note, all residents are already registered into Passport. I know that both of our speakers really encourage questions, comments, and reaction. And so when you ask a question, we will ask you to please mute your phone for the answer so we don't get feedback. You're urged and recommended to ask as many questions as you like. Also, Mary will be monitoring the chat. If you want to put a question into that, she will facilitate getting that to our speakers. I want to briefly remind you of the 2 upcoming programs. On Thursday, October 10th, we will have our annual oncology program, which will be on melanoma. It'll include Dr. Paul Mosca, who's a surgical oncologist at Duke. He'll be talking about staging and surgical approaches, and then the medical oncology management by Dr. Shaw, one of the HEMONC physicians at Duke and part of the Duke Cancer Center. The other program we're looking forward to is Thursday, October 24th. That's the week right before Halloween. Is on acute mental health emergencies. Dr. Reddy, one of our psychiatrists here at Sovah, will be talking about the medical management of the types of acute mental illness emergencies that occur. Carla Pruitt, who's at the Crisis Service Coordinator for the Danville, Pennsylvania Community Services Board, will be talking about local resources, outpatient resources. And then finally, Mary Hoffman, who is an attorney at Huffman Law in Richmond, will be talking about the Virginia statutes that define and how a patient can be retained in hospital involuntarily. This is a really great program, and if you are involved in any way with mental health emergencies, I highly recommend it to you. So this evening, we're delighted to have a program on women's cardiovascular health. I'm so pleased that Dr. Vogel, one of the intervention cardiologists from our Martinsville campus, will be hosting and chairing this program. He'll introduce our speakers. In case you've not had the real pleasure of meeting and working with Dr. Vogel, his background is he received his medical degree from the Diane Medical College and Hospital in India, which was followed by East Tennessee State University internal medicine residencies and cardiology fellowships. And that was then followed by his interventional cardiology fellowship at Georgetown. And it is the link between his being there and Dr. Hashim, who was one of his mentors in his training program that led us to developing this program. And Dr. Vogel, I will take my slides down, or maybe, and we'll have Dr. Shah's on. He can bring his up, and you can say hello and introduce folks. Thank you so much.
Oh, thank you, Dr. Moore, and thank you, Mary, for organizing this CME. And so today we're gonna have like very important topic, that is women's cardiovascular health discussion, and we have two very great speakers. And first, I'm gonna introduce Dr. Shah. Welcome, Dr. Shah. And Dr. Shah is currently an assistant professor at Duke University School of Medicine. He did his internal medicine residency at Johns Hopkins and cardiology fellowship at Cleveland Clinic at Cleveland. And he has been part of several publications, has received several teaching awards and grants, including grants for randomized controlled trials. So without taking much time, we welcome Dr. Shah, and he will be giving us talk on screening women for cardiovascular disease.
Thank you so much for the very kind introduction. Can you guys all hear me okay? Is my audio all right? Just want to double check.
Yeah,
we can be a little bit louder, Dr. Shah.
Okay, sure. Happy to project my voice. And then what I may do as I come and get my screen, as I share my screen, what I may do is I may actually stop my camera because we are having a lot of rain here, as you can imagine. And so in case my internet goes in and out, maybe keeping my camera off while I speak may hopefully help maintain it. So give me 1 second here as I get everything. And can you guys see my screen okay?
Yeah, you're not presenter mode yet, but you're.
Yep, I will fix that. Give me 1 second.
But we can see your slides.
All right, hang in there 1 second. All right, going to presenter mode now. All righty, you guys see like the presenter mode, or do we need to display the settings? Okay, great. Awesome. All right, guys. Well, again, it's an absolute pleasure to be here and discussing this really important topic in screening women for cardiovascular disease. As you guys may have heard, I'm a preventive cardiologist here at Duke and at the Duke Clinical Research Institute. So I have four main objectives I'd like to discuss with you all today. First, to understand the sex-specific disparities that currently exist in cardiovascular disease prevention and management. Review guideline-based recommendations for the evaluation and management of cardiometabolic disease, but also have like a little focus on gender-specific risk. Discuss a new frontier in obesity management. And, someone may ask, well, why are you talking about obesity management when we're talking about screening and cardiovascular disease in women? And you'll see, what I hope I can convince you is that obesity, even though it is a global pandemic, it predominantly impacts females more than males. And then also understand team-based approaches to optimal cardiometabolic risk. But to add context, I'd like everyone to really just understand the current burden of heart disease across the world. So first and foremost, you all may know this, it remains the #1 cause of mortality globally. 224 people per 100,000 die in the US, and their death rate is 238 per 100,000 globally. For context, one person dies every 34 seconds in the US due to heart disease, and one person has a heart attack every 40 seconds in the US. But despite this, the number of deaths due to cardiovascular disease is much higher in women than in men currently. And that is a key disparity that must be closed. Yet, if you look across the board, survey analyses, etc., heart disease is largely viewed as a disease that predominantly affects men. So a huge disparity that I hope I can raise awareness of over the course of the next several minutes here. But to really fight cardiovascular disease, we need to understand what drives risk. And what risk are we talking about? We're talking about the risk of cardiometabolic disease. And I view cardiometabolic diseases as a spectrum of interrelated conditions, starting with hypertension, dyslipidemia, obesity, hyperglycemic diseases such as prediabetes as well as diabetes, fatty liver disease, and of course, chronic kidney disease. And through the course of my talk, I'll go through each of these risk factors and screening tactics for both men and women with a specific focus on women. So let's start with hypertension. So many of you, this is coming straight from the guidelines. So many of you may be familiar with this algorithm, but I'll just review it really briefly for those that don't maybe or are not as familiar. So in cardiology, and I know we have a variety of providers in the audience, that with different specialties or practice patterns, but in cardiology, we're a little bit aggressive when it comes to adequate blood pressure control. And a lot of that is due to a lot of cardiovascular outcomes trials that we've had showing not only cardiovascular benefit, but mortality benefit in more aggressive blood pressure control. So normal blood pressure for us is essentially less than 120/80. I say on average. That's really important, on average, because blood pressure, as you all know, fluctuates throughout a person's day. Elevated blood pressure certainly is anything on average above that. And ideally, we want to keep blood pressure, as you can see here, below 130/80 at most. Now, hypertension we define when we cross that 130/80 threshold, and we're averaging somewhere between 130 to 139/80 to 89, and of course, stage 2 hypertension greater than 1 or equal to 140/90. Now, just because you have hypertension does not always mean you need to be on therapy, okay? And so what the guidelines recommend is you assess someone's 10-year cardiovascular risk, so pretty much doing the ASCVD risk calculator in a primary prevention patient to understand, is their risk high or low, or with 10% or higher being intermediate or low. And if it's not high, then you may be able to get away with non-pharmacologic therapy. But you don't want to just say, okay, you don't need anything, watch what you eat, lose some weight, let's go from there. You want to actually have objective goals to adequately treat it, because those patients may ultimately still need antihypertensive if, despite diet and exercise, they're not getting adequate control. But of course, if their risk is high and you're at stage 1 hypertension or higher, then the combination of non-pharmacologic therapy and pharmacologic therapy is recommended. But we've all seen this. We've all seen that blood pressure can vary in the clinic compared to what happens at home. And so the guidelines and the evidence is really moving to the direction of making sure that we have a good understanding of out-of-office blood pressures before jumping straight to either medication titration or initiation of medication. So you really want to have a handle on blood pressure, okay? And so I listed here on the bottom generally what ambulatory monitors or home blood pressure monitoring averages you're looking for. And essentially, if you aim for less than 130/80, you'll be good. But I just want you guys all to appreciate that there can be some variability. And it's important to take home from this is it's really important to understand blood pressure both in the clinic setting and out. However, hypertension is a really big deal for women. So if you see a woman with hypertension, definitely be concerned about risk, because this is just one study, but there are numerous ones. Hypertension in itself is independently associated with incident MI, and more so in women than men. This was a study from the UK Biopain, kind of one of the landmark studies, kind of looking into this. 28% female cohort, however, a diagnosis of hypertension or high systolic blood pressure was associated with higher odds for MI in women compared to men. So I talk about blood pressure, but then I want to tie in the sex-specific risk when it comes to that. And then women also of childbearing age, when they become, or females become pregnant, there are also different strategies to managing blood pressure in these cases. Now, I don't want to necessarily read off all of these different strategies. I kind of put this up here more for reference. But the biggest thing to remember is that ACE inhibitors, ARBs, renin inhibitors, and MRAs are contraindicated in women who are pregnant, of course, but those also want to be cautious in those that are trying to become pregnant as well. And we'll talk a little bit more about how that conversation goes in other parts of the cardiometabolic risk spectrum. But That is the key takeaway. And again, I've listed some strategies for both oral therapy as well as in the urgent setting therapies that is recommended. And this is from the American College of OB/GYN. Now, moving on to dyslipidemia, this is probably also familiar, this diagram, to many of you. In the primary prevention setting, when the guidelines recommend using the ACC-AHA pooled cohort equation to estimate 10-year risk. Again, this is primary prevention, not secondary prevention, meaning these folks have not had a prior MI or have not had a prior stroke. And the risk calculator puts these patients into 4 different buckets. You have a bucket of low risk, a bucket of borderline risk, and you can see the numbers of risk over 10 years, 5 to 7.5%, intermediate, or high. The foundation of what you do with each bucket of risk always is lifestyle modifications, exercising well, eating well, and I can talk a little bit more about what that means. So let's say your risk is low, okay? Then if all else is equal, monitoring is fine, but as long as you're actually monitoring, you're not just waiting another year and then reassessing them, you're actually making sure they have objective goals. Either if they need to lose weight, what are the markers they're looking for? What are the milestones they're trying to get? If they're just trying to maintain, then making sure they are maintaining an ACC-AHA proven lifestyle in terms of maintenance exercises and things of that nature. Those that are in the borderline or intermediate risk, this is where shared decision-making and conversations and sex-specific or patient-specific risk enhancers come into play. Because someone may actually be at much higher risk than is being shown on the pooled cohort equation and may benefit from lipid-lowering therapy earlier. And of course, high risk, the recommendation is to move into lipid-lowering therapy sooner rather than later. Important to remember that this is just a pooled cohort equation. It's an estimate over based on a series of cohort studies. And it's very possible to overestimate and underestimate risk. It's also important to remember some important caveats, right? This is a primary prevention cohort or population. Does not include people who have a diagnosis of diabetes and does not include people who have an LDL that is over 190 or higher. And of course, between the ages of 45 and 75. Those are important caveats that not a lot of people understand. And ideally, you would use this risk calculator in patients not already on statin therapy. But even more importantly, females in general, due to female-specific markers of risk, which are not taken into account with this pooled cohort equation, often are underestimated in risk. And so we need to really, really, really keep in mind things like risk enhancers. Risk enhancers are extremely important. Those are a combination of personal characteristics, such as the premature family history, a persistently elevated cholesterol, South Asian ancestry, comorbidities, inflammatory diseases, and certain biomarkers. And the point here is that traditional risk factors may only be the tip of the iceberg, and there's more than what meets the eye. But for women in particular, it is extremely important to understand if they've had these particular conditions. So preeclampsia being one of them, because that is associated with downstream cardiovascular events later in life. Premature menopause, that is also associated with higher risk later in life. And so these things are important factors in the history taking when it comes to deciding between you and your patient the benefit of lipid-lowering therapy early. So if you're still not sure, it's also a good opportunity to consider calcium scoring. Calcium scoring currently has a 2A indication in the guidelines. And as more and more guidelines from other parts of the world are coming out, it's getting a stronger and stronger recommendation as we're getting more and more evidence on the prognostic utility of coronary artery calcium scoring. So right now, our guidelines in the US, we typically recommend that we get coronary calcium in those intermediate risk where there's uncertainty if there's going to be a benefit of lipid-lowering therapy or not. Moving on to secondary prevention. Now, these are people with established atherosclerotic cardiovascular disease. Currently, our guidelines, at least from 2019, really essentially push for an LDL of under 70 in these folks. And so almost everyone with secondary prevention will need to be on some type of lipid-lowering therapy. Of course, statins are the easiest ones to reach for. They're cheap, They're generic and easy to prescribe. And so they're typically recommended as first line. However, many patients do develop intolerances, whether we believe it or not. It's an intolerance to the patient, and adherence is a big issue. Many of you guys may have seen literature that suggests that if you follow a patient that has established ASCVD over the course of a year, there are a significant proportion of people that are lipid-lowering therapy. And so it's extremely important to make sure that we are following these people regularly. But that being said, aim for an LDL of under 70. It doesn't matter where you may want to even aim lower, which I wrote out over here. And I mentioned lower is better because there's a movement here in the US to really push the LDL as low as possible, especially in high-risk ASCVD patients that are elderly, have heart failure, have diabetes, and multiple events. And now there's an aim to push LDL less than 55 in these high-risk ASCVD patients. And that is consistent with guidelines from Europe. And what that does is that it actually suggests upstream combination therapy in many cases, especially if you don't feel you're going to be able to get your LDL in a very high-risk patient low enough, okay? So that means a statin plus ezetimibe. Maybe you need a statin, ezetimibe, and a monoclonal antibody PCSK9 inhibitor, or some combination. Maybe they're statin intolerant and PCSK9 inhibitor plus ezetimibe. We in cardiology really would love to partner with our primary care colleagues to really help patients get to their guideline-based LDL thresholds. But despite these clear guidelines on what to do with LDL, in established cardiovascular disease patients, there are still sex disparities that exist to this day. This is a study we did across 5 health systems across the US, diverse health systems. And what I really want to point you out to is when you look across, these are patients with ASCVD. I have my mouse. I don't know if you guys can see it, but 40% of an ASCVD population across a cohort of 200,000 patients had an LDL under 70. Despite clear guidelines, and this is in contemporary practice. We presented this at the AHA just in 2023. 60% or half the patients with ASCVD did not have a controlled LDL. That is terrible when it comes to how the way when it comes to us optimizing risk. And unfortunately, disparities clearly exist. If you look in terms of the proportion of females that were at control or at goal LDL, that was only 35%. And about half of females did not have LDL at goal. So it disproportionately affects females compared to males. Furthermore, in multivariate regression analysis, being female had a higher likelihood of not achieving LDL goal. So that's a big problem that we definitely need to understand and be mindful of when we see these patients in clinic. So what do we do about folks who are of childbearing age, for instance? What is our strategy here? I mean, do we start lipid-lowering therapy right off the bat? And in my practice, what I do, and this is sort of supported by evidence, is I tend to actually not prescribe statins or other lipid-lowering therapies in women of childbearing age unless they are at extremely high risk and there's no plans of getting pregnant. And so that's a conversation to have with patients. And this is a kind of clinical practice update we wrote in current cardiology reports in 2022. I went ahead and put the reference down there. Our group sort of kind of gave sort of a guide on how to have these conversations. Does that mean you have to like follow this to the dot, but have some sort of guidance in terms of how you would approach this. But typically, if there's someone who has familial hypercholesterolemia, for instance, has an extremely high LDL, has an extremely strong family history, or even a personal history, and they're not planning on getting pregnant anytime soon, I do start lipid-lowering therapy with the understanding that if they do decide to get pregnant, to stop lipid-lowering therapy 1 to 3 months prior to conception and hold off lipid-lowering therapy until after they are done nursing, and then restarting after that. So that way, instead of having a sustained exposure in extremely high-risk patients, of high LDL to the endothelium, it kind of comes in peaks and valleys, which we've also seen has been more beneficial than having sustained elevated levels. But in general, if they don't have familial hypercholesterolemia or otherwise low risk, close monitoring with good lifestyles, typically my approach. Because these drugs have not been studied in women who are pregnant, because you just typically can't enroll those patients in clinical trials. So moving on to diabetes, the next part of our spectrum of cardiometabolic risk factors. Diabetes, I like to say, is our problem too. The prevalence of diabetes is on the rise across the entire country, and it is directly associated with cardiovascular events. And in women in particular, women have been shown to have a higher all-cause mortality if they have a diagnosis of diabetes, as well as a higher cardiovascular mortality compared to men across the board. And I mean, this is a study looking across multiple individuals, millions of individuals. One of the landmark studies that really kind of put this on the map. So that's a problem. That's a huge problem. So this is our guideline approach to managing diabetes, and in particular, be very mindful of our female patients. You definitely want to have a good diet, a carb-controlled diet for sure. You want to exercise at least 150 minutes of moderate or vigorous activity a week. You want to modify every cardiovascular risk factor outside of the diabetes as you can, considering metformin up front. But why I even bring this up is because this is an opportunity to really start thinking about SGLT2 inhibitors or GLP-1 receptor agonists, especially if they don't have good A1C control, or they have high atherosclerosis burden, or are obese, okay? And we have a ton of data on the benefit of SGLT2 inhibitors and GLP-1 receptor agonists. I'll just start with the SGLT2 inhibitor. These trials that I've kind of summarized here were initially in patients with just type 2 diabetes that have shown reduction in major adverse cardiovascular events, reduction in heart failure hospitalizations, and all-cause death. Then you compare these drugs, what they do in patients without type 2 diabetes, and you see more or less the same benefit, suggesting that there is benefit across multiple trials in whether you have diabetes or not. Of course, patients with CKD, we've seen that there is a decreased progression of renal disease with SGLT2 inhibitors. So, and it's very clear, I'm sure to many of you, the benefit in heart failure. So if you have a patient that is diabetic or has heart failure or CKD, definitely think about the SGLT2 inhibitors. Similarly, GLP-1 receptor agonists, I won't talk about obesity just yet, but I'll just talk about the other benefits of GLP-1 receptor agonists that have been studied. So in patients with type 2 diabetes, there's been a significant reduction in major adverse cardiovascular events across trials. Even in patients with HFpEF, you had the STEP-HFpEF trial that improved quality of life and functional status, but also had biomarker improvements. And then more recently at ESC, we saw the STEP-HFpEF diabetes trial, which showed similar improvement of quality of life, of course, and weight loss, though had overall less weight loss than the STEP-HFpEF trial, but equal benefit, suggesting maybe a mechanism of these drugs independent of the weight loss that is providing benefit. Of course, I believe the weight loss that these drugs also provide a significant benefit, but there's suggestion that there may be other mechanisms that improve cardiovascular risk. Nonetheless, we should certainly consider these drugs based on the amplitude of evidence as cardiovascular therapies. So don't be shy in thinking about these drugs, and certainly phone a friend, refer to a cardiologist. We're in this together around the patient. So moving on to obesity, obesity has reached actually pandemic proportions over the last several decades. We have about 650 million people worldwide that are obese. And if this trend continues, 2 billion adults by 2035, including children and adolescents, will be obese. So this is a problem. More importantly, there are also disparities. You see, this is a non-Hispanic white prevalence, so still high. The overall prevalence I put here on the left. But then look at Hispanic and look at non-Hispanic Black prevalence is significantly higher. So there are disparities here as well. And then this is another study that we published looking at sort of trends in weight across genders. And so you can see here at extremes of weight, so low BMIs and higher BMIs, that there's a predominance of females compared to males. And just focusing on obesity classes, if you look at class 1 obesity in this particular cohort, 50%, 50-50 essentially men and women, but then class 2 obesity, 64% female, 35% male, 70 in class 3, 70% female, 30% male. So there's a linear distribution as you get into higher class obesity with a higher proportion of females compared to males. And this is just one cohort we did. This is multitude of studies showing very similar effects. So I bring that up because this is a disease that definitely affects both men and women, but women in particularly more so than men. And so you want to remember the important lifestyle modifications. In general, however much you're moving, try to move more. However much you're eating, try to eat less. Nothing beats the very basic of basic formula that more calories burned is better than calories taken in. Burn more than what you take in. That's the secret sauce. But it's not just about exercise. I would say 90 to 95% of weight loss also is your diet. So whatever you do, you got to make sure it is sustainable for life. Having a structured exercise program can certainly help. Remember that 150 minutes a week at minimum rule by the ACC and AHA for moderate intensity or vigorous intensity exercise, limiting caloric intake, of course. And again, thinking about low carbs or Mediterranean-based diets, of course, those have the best evidence. And it's important to remember that even a 5% body weight loss is associated with significant metabolic improvements, blood pressure, LDL, glucose levels. So you don't have to necessarily see the results in the mirror just yet before having improvements in your cardiometabolic. Study from that was published in the Journal of American College of Cardiology earlier this year, many of you have seen that females actually gain more benefit with similar exercise levels compared to males. So if you look here at both these tables in terms of all-cause mortality and cardiovascular mortality, if both a male and a female do the same amount of exercise, females actually tend to have better outcomes than males. So it's patients to maintain some level of an active lifestyle because they will have good outcomes. So now moving on to just kind of this change in obesity paradigm that we're all the other benefits that GLP-1 receptor agonists have in terms of cardiovascular risk and event risk, but obesity is sort of really what put them on the map. And so this is just an example from the STEP 1 trial, which actually included 74% females, which is very unusual for cardiovascular clinical trials. There is a movement to be more inclusive in our enrollment of patients for clinical trials, but 74% female, which is remarkable. And you can see that there's about a 14.5% weight loss from baseline at 2.4 of semaglutide compared to placebo. And the proportion of weight loss, it can reach almost up to 20% from baseline, which is quite remarkable. We see similar results with another agent called tirzepatide. It's not quite a pure GLP-1 receptor agonist, but again, the SURMOUNT-1 trial, which kind of really put our eyes on tirzepatide, included 67.5% female. And again, profound weight loss from baseline. A little bit about this question that comes up probably a lot in clinical. What if I stop? What's going to happen, right? So the best data we have is from the STEP 1 extension trial, which after the STEP 1 trial I showed you before with that 14.5% weight loss with semaglutide, after week 68 in that trial, there was a portion of the cohort that stopped the drug. And in that cohort at about week 120, they regained about 2/3 of the weight that they had lost. And so important to know that there is at least as far as we know, there is a significant chance of weight regain. And so important to understand sort of the importance of a symbiotic relationship of being on the drug, but also making sure you adhere to good lifestyle modifications to help keep as much weight off as much as possible if you don't want to be on this drug for life. That being said, with the weight loss, there were cardiometabolic improvements, right? LDL, glucose, blood pressure, and in addition to the weight regain, you also saw higher LDL, higher blood pressure, and uncontrolled glucose levels as well. So it all is concordant. I throw the SELECT trial in here because it was a pretty big breakthrough in cardiology. So the SELECT trial was a trial that looked at patients with established cardiovascular disease. It was a randomized double-blind controlled trial of semaglutide 2.4 milligrams versus placebo. It included patients with a BMI of 27 or higher, again, with established cardiovascular disease, with no diagnosis of diabetes, okay? And the endpoint was major cardiovascular events, so CV death, non-fatal MI, non-fatal stroke. And what they found was semaglutide was superior to placebo in reducing incident CV death, non-fatal MI, and non-fatal stroke. And that there was a mean reduction of body weight of 9.4% versus 0.9% in the placebo by week 104. Okay, great. You lost weight. That's awesome. But what's important to remember, and I don't know if you guys can appreciate on these curves, that the curves actually start to separate. And again, the primary endpoint is major adverse cardiovascular events, not weight loss. The curves start to separate before weight loss is even happening. And so it kind of brings up the hypothesis of, is there something else that is providing cardiovascular benefit in addition to weight loss? Again, important to note, this trial only can include about 30% female. But I bring this up about this other thing that could be going on that could be improving cardiovascular risk is because if you look at the Harmony outcomes, which looked at albiglutide, there was no difference in weight loss, but there was a 25% reduction in myocardial infarction in the albiglutide arm versus placebo. So more food for thought. But if you're interested in prescribing these agents for patients, of course, many of you guys on this call know that there are plenty of insurance barriers in prescribing these agents. And so, the FDA indication is one thing, but the payers have to pay for it. And that's a whole nother conversation that we can certainly have if anyone's interested. But in terms of the FDA indications for both of these drugs, semaglutide and tirzepatide, it's pretty much either being overweight, so BMI of 27 or higher with a weight-related comorbidity, or being at a BMI of 30 or higher. And important to remember in tirzepatide too, there's actually now indications for pediatric patients aged 12 years and older who have a BMI above the 95th percentile. So there is more and more notice of trying to address this even in our younger generations. A few pearls on prescribing these agents. It's contraindicated in patients with a personal history of medullary thyroid cancer. The side effects are mostly gastrointestinal, nausea, vomiting, bloating, constipation. So it's important to start at lower doses and step it up. Again, keep the risk of acute pancreatitis and gallbladder disease in the back of your mind when starting these agents. Not saying that's going to happen, but just understand the patient that you're prescribing it for. And again, start low, up titrate every 4 to 6 weeks. I give an example here of semaglutide as well as an example for tirzepatide here. You want to tolerate to max tolerated dose because that is the dose where people confer the most weight loss. All right. So we certainly still need to do better in understanding cardiovascular risk in women. Okay. I went through a whole cardiometabolic spectrum in my presentation, but there are several female markers of risk that we need to understand. So I talked a little bit about how hypertension and diabetes and their impact on female cardiovascular risk compared to men. I talked about the history of preeclampsia, gestational hypertension, gestational diabetes, same thing. Gestational diabetes, gestational hypertension downstream can lead to actual diagnosis of diabetes and hypertension. I talked about premature menopause. When menopause often hits, people's LDL skyrocket. And so it's also important to understand that. On top of that, their metabolism changes. And so it's easier to hold on weight, also increasing their risk. Many females also discuss with providers about hormone replacement therapy. And in general, there's a lot of debate on how beneficial is that. And you have to take the risk versus benefits, of course. The key here is to make sure that the estrogen and progesterone are balanced together and you're not just doing progesterone alone in terms of thrombotic risks and so forth. But we need to understand that. And the way to understand risk in women, to better risk stratify women, is to include them more in clinical trials. I mentioned the SELECT trial and the SURMOUNT-1 trial that had about almost 65% higher recruitment of women. That is mind-blowing. And as you see more cardiovascular trials come, my hope and my expectation is that you're going to see at least 50% enrollment of women. This is something that we're all striving to do, but we'll better understand what works for our women and female patients. And then studying the sex-specific markers of risk that can influence management. What else is out there? There's been a lot of interesting data recently, observational, of course, that even breastfeeding is associated with lower cardiovascular risk down the line. So we need to understand these things. That's just one example, but there's so many other. We need to understand this more. Why is it that females tend to do better in terms of outcomes, doing the same amount of exercise in men? What is different? Like what's driving that? We need to understand that more. And of course, we need system-wide changes across the health system, community, to really bridge these disparities in care, because both women and men both have a risk of heart disease. It's not like it affects one sex more than the other. We need to treat them both equally, and we got to be able to bridge those gaps. So in conclusion, females are just as much at risk for cardiovascular disease than males. Several guideline-based approaches exist to modify cardiometabolic risk, but also keep in mind those female-specific risk factors. Disparities exist by sex and must be accounted for at the provider, patient, community, and health system level. And we most certainly need to include more females in clinical trials, as well as in research in sex-specific differences in cardiovascular risk. With that, I will conclude. Thank you so much. I'm sorry if my internet was acting up. That's totally on me. It's just bad weather here, but it's always great to be on the call with you all. So thank you so much.
Thank you, Dr. Shah. That was a great talk. Actually, I do have a few questions for you. Actually, I think you highlight very important points regarding, primary prevention and secondary prevention, and especially like disparities in the, males and females regarding the cardiovascular health. So I think the next big thing in our cardiology field is like measuring the LPA level. So I noticed like you are gonna be a part, like I think you're like running a trial in Duke Oceana. So I was gonna ask you like, because we still don't know like who to screen and when to screen, and we do know like it is associated, higher levels are associated with higher risk of stroke and cardiac disease. So what is your approach on these kind of patients, and especially like young women, like when should we order LPA level, and the most importantly, does lifestyle modification helps in decreasing them or not?
Yeah, that's a great question. And if you ask me as a preventive cardiologist who's biased and really works in this field, I screen everybody once in a lifetime. And actually, if you look at the European guidelines, the Europeans actually say also screen everybody at least once in a lifetime to understand the genetic risk of a patient and to understand who is at extreme tertiles of elevated LPA that we need to be more aggressive in treating for. Now, that being said, that doesn't work for everyone who may not be able to afford getting tested or really wants to understand the point of getting tested. And so what I recommend in general, if you're not going to test everyone who's nervous about their risk, definitely want to test the young people who have extremely strong family histories of cardiovascular disease, young people who themselves have had cardiovascular disease. Everyone with familial hypercholesterolemia, 20% of patients with familial hypercholesterolemia have elevated LPA. Anyone in general who's worried about their own risk, but also first-degree relatives of people who have elevated LPA. So when I have someone that comes to me with an elevated LPA, immediately my goal, and this is based on observational data more than anything, it'll be important to get the outcomes data from the trials that are studying direct inhibitors of LPA. But I try to lower their LDL as low as I can, ideally less than 70. I sort of treat it like an elevated calcium score. There's good data, observational again, it's not, so it's all, keep that with a grain of salt, but there's more data coming out suggesting the benefit of aspirin in these patients. So if their bleeding risk is low, I do consider aspirin therapy in these patients. And then in addition, I screen everyone's family. I do cascade screening, so make sure all of their first-degree relatives are screened for Lp(a) to identify who would benefit from cholesterol-lowering therapies earlier rather than later. And then, of course, I keep them in the back of my mind for opportunities like clinical trials and those kind of things. Of course, it's not as you know, it's not clear yet that these clinical trials are going to have positive outcomes. We're just assuming based on the myriad of data that's out there suggesting that LP has a causal relationship between MI and stroke. But I try to modify what I can in those patients.
Thank you. And lastly, what do you think any role of PCSK9? Because I don't think these patients I mean, we can start studying, but the data is still controversial. But do you think PCSK9 will have any role in decreasing the LPA level? And also, do you ever follow those levels?
Yeah, that's a great question. So, if this was a perfect world, I think in patients with elevated LPA, if we could access PCSK9 inhibitors easier, payers were ready to approve them easier. Of course, I think that putting people on PCSK9 inhibitors that have elevated LPA, we actually do have post hoc analyses from the Fourier trial, which studied evolocumab and others, Odyssey outcomes that have shown benefit in LDL reduction with PCSK9 inhibitors in patients with elevated LPA more than if they didn't have elevated LPA. So sure, absolutely. The problem that we face, unfortunately, is that there's not an indication for at least a label expansion for PCSK9 inhibitors in patients with elevated LPA alone. So you're sort of stuck in that regard. I think, so what I try to do is I try to see if in this patient with elevated LPA, are they truly primary prevention, or do they have some level of atherosclerotic disease that I need to worry about, or vascular, like carotid disease, peripheral disease, cerebrovascular disease. That stuff oftentimes gets overlooked. But if they do, then you have an opportunity to get a PCSK9 inhibitor, especially if they're statin intolerant or the statin is just not enough.
Okay, no, thank you. I think this is very important for primary prevention, and thank you for your opinion on that. Is there any other questions? Hey, Dr. Hashim. Do we
No
have any other?
questions in the chat.
Okay, let me see. I think they are asking your presentation slides.
That's taken care of.
Okay. All right. Thank you, Dr. Shah, for your time. And it was very helpful. And I hope a lot of audience got some knowledge about primary prevention and secondary prevention of cardiovascular disease, especially in women health. And then we move on to our next speaker, Dr. Hashim. Welcome.
Hi, Sukdeep.
Hi, Dr. Hashim. So let me introduce Dr. Hashim quickly. So Dr. Hashim is currently an assistant professor at Georgetown University, and he's a faculty at MedStar Washington Hospital Center. He did his internal medicine residency and cardiology fellowship at Rutgers, New Jersey Medical School, and interventional cardiology from Montefiore Medical Center in Bronx, New York. And he's very active in academics, has several publications under his name, has several teaching awards, and he's currently a principal investigator of several trials, including coronary microvascular dysfunction registry. And we will be part of that registry soon, like Sovah Health Martinsville. And lastly, I would like to mention that Dr. Hashim is a great teacher, and he's my mentor as well. And in the cath lab, I learned a lot from him, and I was his fellow just a year and a half back. So we welcome Dr. Hashim, and Dr. Hashim, we cannot wait to hear your talk.
Oh, thank you. Thanks, Sukdeep. Thank you for this intro. I certainly don't deserve much of you said. You're a friend. There's no mentor here. I learned from you as much as you learned from me. I'll share with you my slides, and then I will start to respect time. You see my slides?
Yes, we can see your slides.
Perfect. Excellent. So as Dr. Bogle just mentioned, I work at the Washington Hospital Center down in Washington, D.C. We're a big tertiary care center. I do interventional cardiology, different to Dr. Shah. So when it's too late and you don't listen to Dr. Shah, you'll end up on the table and I'll end up doing a procedure on you. So take your statin, make sure your PCSK9 is on schedule. because I always tell my patients, by the time you see me, we missed the train. Now we're in the salvage mode, trying to treat something that could have been prevented. But today I'm going to switch gear to talk about a different approach to chest pain evaluation in women. Women always gets kind of washed away or pushed aside when they complain of chest pain, and that goes to a social stigma that has developed over a year. That if a patient, a female patient, get chest pain, she doesn't want to put her family in trouble. Who's going to put the kids to bed? It's always, the woman carries the world on their shoulders. They don't want to call 911, and then we ended up having catastrophes in women because we know coronary artery disease and cardiovascular disease in general, it's a disease of men and women equally. It does not discriminate who gets it and when they get it. So I'm going to take you into a different approach, because I do believe evaluating chest pain in women now, it needs to be away from only an angiogram. We need to have another step to understand what's happening. And I'm going to probably mention an approach and a technology that's available with Dr. Bogle now. That's what he was talking about, microvascular disease. So whatever I'm going to talk about here, you have it in your hospital, and you'll be able to order that step beyond an angiogram to understand chest pain. I'm going to start with a case. And I don't expect anyone to solve the mystery. Just a regular case from every day. We have a 75-year-old woman. She had a history of hyperlipidemia, GERD, cervical radiculopathy, and when I always ask myself why women is tagged with these medical disease or medical conditions, this patient, from just looking here, she had long-standing chest pain. That's why she was referred to a gastroenterologist first, who did an endoscopy, an EGD, and they say, you know what, you have gastritis. Well, guess what? If you have 2 coffees a day like I do, you will have acid reflux. It's part of who we are. The food we eat, the time of the day when we eat, we all have certain level of reflux as we get older. And then when the gastroenterologist couldn't solve the problem, she continued to have chest pain. She landed on an orthopedic spine surgeon, because I have chest pain. Well, they told her, you know what? It's probably like cervical spine that's radiating down your arm. This is not chest pain. Obviously, she gets an MRI. And again, if you do just from us watching YouTube videos on your iPhone or your iPad, you will have cervical radiculopathy. So it's part of life that I will have some disc bulging or some arthritis in the cervical spine. So she continued to have chest pain despite the fact she's been everywhere. But guess what? One day she got very lucky, because now she had chest pain that took her to the emergency room, and the emergency room, they did troponin, and they found that she has an STEMI. So now it's a different story. No one can deny her chest pain anymore, because there is objective finding of troponin elevation, cardiac biomarker elevation. For that, she underwent a coronary angiogram, and Dr. Bogle, I'm just going to use you as an example, he took her to the lab, and then guess what? He found an OM stenosis, an obtuse marginal branch, and he decided to put a stent in 2018. Lab goes by, she continues to have chest pain despite the fact Dr. Bogle put a good stent. And so she said, you know what? He probably doesn't know what he's doing. Let me go to Hashim. So Hashim repeated the angiogram in 2019 and found that the stent Bogle did is amazing, and there's nothing else. And she continued to have chest pain. So she said, you know what? Hashim doesn't know what he's talking about. Let me find another cardiologist. She went to another cardiologist who decided to repeat the cath, because now he saw something in the LAD that could have been evaluated by FFR, by physiology, by understanding the gradient before and after stenosis. So he did that, and guess what? There is no significant gradient across the LAD 50% stenosis. So now she went back to her cardiologist and said, you know, I had 3 caths already, and no one can figure out. And even the last guy that you sent me to, who actually did some assessment, couldn't find anything. What do you want me to do? He said, you know what? Just take nitro. Take nitro, you'll feel better. She takes the nitro. She can't even tolerate the smallest dose of long-acting nitrates, because she gets very dizzy and hypotensive. So she was referred to our institution for a cath. And I'm going to show the angiogram. This is the right coronary artery. Yes, it has some mild disease. She has hyperlipidemia, but there is nothing to brag about. There's nothing to go to court for. I took another picture, and then I see a picture now of the left main coronary artery. The circumflex is going down this way. You could see the silhouette of the old stent from 2018. It looks perfect. It is actually positively remodeled. It's oversized and looks better than ever before. And then I see the LAD, and I said, maybe another picture of the LAD. And oh, I see this LAD. It has some mild disease. And if you pay very close attention here, there is some haziness. It looks like a 40-50% mid LAD. And I realized that this was the LAD that we did physiology. But then, I was like, maybe there's something else. Let me repeat physiology. Maybe it got worse from 2020 to 2022. And this is, as you see, I put a physiology wire. It is a technology available everywhere in the US. Many manufacturer makes this. And then I put it down, and I get something called RFR, which is resting full cycle ratio, a very well disseminated value that I use, and everyone and any interventional use. And if you have a value of 0.89 or below, you have a significant narrowing stenosis. And if you have a value of above 0.89, yes, you have a gradient, but that gradient does not necessitate stent or bypass grafting, because the data is very clear. 0.89 and below is a problem. 0.89 and above, there's no problem. The value here, as you see, is 0.93, which is telling me there is a stenosis of a certain level, but it's not that significant. Then I said, you know what? Maybe if I exercise her, if I simulate her exercise by creating what's known as hyperemia, I might be able to provoke her gradient. Maybe when she's resting and doing nothing, life is good. But once she's walking, she's going to have angina. Let me provoke that by making her exercise in the lab. And we don't exercise patients in the lab that often anymore, except when we do right heart cath. We do adenosine, which is a hyperemic agent that simulates, in the chemical aspect of adenosine, simulates exercise to a very close level. And a value of 0.80 or 80 and below is a problem. 80 and above is no problem. That's the cutoff we use. We got a value of 0.91. So again, there is a 50% narrowing, but that narrowing is not enough to explain her symptoms. I cannot put a stent. I cannot send her to bypass. So what's your next step now? She's been through 3 caths minus the 4th, and no one can figure out this woman with chest pain. She's seen a gastroenterologist, done. She's seen an orthospine, done. She's seen a pulmonologist, done. There has to be a missing piece here, and women cannot be dismissed anymore because there are ways to understand why they get chest pain. This is the problem. The problem when Dr. Bogle trained with us, and many institutions in the country, we pay so close attention to this. We are very good in angiogram. We look at the right coronary artery, the left circumflex, the left anterior descending artery. We see narrowings. We send patients to bypass. They come in with STEMIs or heart attacks, and we fix those. But if you look at the limitation of angiography, angiogram is a very good tool to show you the main highways, maybe some of the main exits, but all the small streets that brings packages to your home, it's not seen by angiogram, by a regular angiogram, and that's what's known as the microcirculation. We care about the main arteries because when we go back to med school, to nursing school, back in the basic science lessons, we understand that the circulation, the coronary circulation, splits into 2 components: a conduit vessel or conduit vessels. These are the main highways, the floodgates that brings the blood. But when you look at the function contributed by these conduit vessels, is only 5% of the resistance in the circulation. Most of the gas exchange, the energy expenditure, the oxygen in and out, the systole, the diastole happens by small capillaries called the microcirculation. And that microcirculation accounts for 95% of the resistance and the function of the heart circulation. But you're going to ask me, but hold on. So why would we put a stent in the conduit vessel all the time? Well, because without these conduit vessels, that 95% is deprived of its function. They rely on the delivery of the blood, and then they will take up from there. So having said that, if you have plaque building up, if you have atherosclerosis from LDL, from bad cholesterol, from bad triglycerides, you will have plaque building up in a large conduit vessel. Imagine what's happening in the small microcirculation in the prearterial arterioles, which means that a lady or a patient with risk factors, diabetes, hypertension, hyperlipidemia, does not exclude them from having microvascular disease, because the culture we have in training and as we practice, if I see a patient that comes to the lab and I see no blockages, I say, you know what, you have microvascular disease, you have spasm, go home. So we need to be a bit more specific in understanding what's happening. Now, coronary microvascular dysfunction is a link between a lot of conditions that we treat as cardiologists and we see in our wards, inpatients, outpatient observation unit. There are many patients that actually come to the lab because they have an abnormal stress test, and then we do a cath, and then we say, you know what, no blockages, everything is good, keep going. We are very good in ruling out, but we are not good in ruling in. I could tell you don't have a significant left main stenosis, but I did not tell you what you have. And each one of us, cardiologist, invasive or non-invasive interventionalist, we always encounter patients in our practices when they ask us, so what's wrong with me then? If you did a cath, you did a stress test, I have chest pain, you sent me to have an invasive procedure, and you told me you have no blockages, so what do I have? That's when microvascular dysfunction could play a role. Same thing goes into condition that we treat, we see in our emergency rooms and cath labs, patients with Takotsubo. What is Takotsubo? Oh, a woman gets angry, gets excited in her son wedding, or God forbid, a loss of someone in the family. They come to the emergency room, elevated troponin, ugly looking EKGs. We activate the lab. We take them to the cath lab. On a Friday afternoon, you take pictures and the staff look at you. Is that what you kept us for? There's no even a blockage, but there is a significant wall motion. Takotsubo is related to catecholamine surge that could actually explain not by microvascular dysfunction, but I do believe microvascular dysfunction play a role in the prognosis of Takotsubo, which means if my microvascular dysfunction is severe, I might not recover Takotsubo. And if it's severe, I might have recurrent Takotsubo. If my microvascular dysfunction indices are better, I will have better outcomes from my Takotsubo attack. And so on and so forth. For sake of time, cardiomyopathies with infiltrative cardiomyopathy, amyloidosis, sarcoidosis, many conditions microvascular dysfunction or microvascular function could be part of the story. How significant this is? This is, if we look back into any cath lab, I don't know how many of you work in a cath lab, it's almost a rule of thumb. If you get 4 patients with an abnormal stress test presenting to your cath lab for coronary angiogram, 1 out of 4 will get a stent. And the reason that happened, not because the cardiologist who ordered the stress test is trying to make money and doesn't know what they're doing. That absolutely has nothing to do with that. It's about the positive predictive value of a stress test. It's a well-known statistic that if you order mammogram, you will pick the smallest calcification that will lead to ultrasound biopsy, and then God forbid if there's cancer, you picked it up. Same thing with colonoscopy. Screening tests such as stress test, it depends on why you ordered the stress test to begin with, the likelihood of you having a problem. So, which means the positive predictive value, it's defined. 4 patients with positive stress test, 1 will have a stent, 1 might have FFR assessment, intravascular imaging assessment, there is a 50% lesion, 60% lesion, and 2 will be told everything is good. And that's from NCDR registry. That's from registries national in the US that we track patients that way. If you take those 2 patients that were told everything is good, leave the cath lab, so what do I have? I don't know. If you bring those 2 patients in and you test them for microvascular dysfunction or vasospastic analysis, you will discover 30 to 50% of them to have a diagnosis of microvascular disease. So that is a very alarming sign that many dismissed patients from the cath lab with chest pain, with abnormal stress test, matter of fact, they could have microvascular dysfunction as their diagnosis. Now, why this is important? It is important today because I'm addressing this condition in women. It is a disease that affects women more than men. 2/3 of the population, we believe, that has ischemia with no obstructive coronary disease, or INOCA, it's 2/3 of that population is women, 1/3 is men. So it's a disease that unfortunately favors women to have more issues with their microcirculation. Don't want to bore you with more interventional stuff, but this will take us back to the non-invasive cardiologist in this meeting. People will tell me, hold on, stop. So we knew this. I can order a PET CT, and I could tell you your coronary flow reserve, CFR, and then and if it's low, you have microvascular dysfunction. We're going to debate that in the next couple of slides. Here we go. CFR, the way I understand it, and in layman language, coronary flow reserve is the capacity of human coronary circulation to augment the coronary flow in response to exercise. Simple words, I'm sitting talking to you, I eject my coronary flow is 2 liters per minute. I just picked a number. If I run now up and down the stairs, I will have to have my coronary circulation has to give me at least double that value. And the 2O has to be 4 liters per minute because I'm exercising. My heart is asking for more blood. You should be able to augment. And that's the CFR, is the ratio of your flow at exercise and flow at rest. And you get CFR. Where is the problem? The problem, CFR could be low, or you cannot augment if you have LAD disease, or if you have microcirculation, because the coronary flow is representative of the entire coronary tree, the conduit and the microcirculation, which means if you have a 90% LAD stenosis, do you know why you get chest pain? Do you know when you have 100% occluded LAD in a stem, you have chest pain? Because you cannot augment your flow. And if I put a stent, I will restore your coronary flow reserve and you circulate blood and you have no more chest pain. And that's the essence of angina. That's why we put stents. That's why we do CABG. But the question becomes, what if you, like our lady, she's having pain, but her LAD is normal, her circ is normal, her RRCA is normal. Where is the problem? Well, if your CFR is low, by default, this is not augmenting, this is normal, then you have microvascular disease. And that's what the PET CT will tell you. The issue here that there are multiple conditions where CFR is low, but your epicardial and your microcirculation is normal. And we will have some examples when we get down the lecture. So the question now, I need a specific index to tell me exactly where am I missing my augmentation power if there is no blockage in the main arteries. Well, that's called the index of microvascular resistance. This index is very easily obtained in the cath lab. Dr. Bogle and myself, we can give you that number with a very simple procedure in the cath lab. So this is what I do for a living now. I get a patient from any cardiologist in the area saying, you know, I have a patient with symptoms suggestive of myocardial ischemia. And then they could do a CT scan, they could do a nuclear, they could do stress echo. I don't care what they do. Whatever is available, they will do. And they will say, you know what? We found ischemia in the LAD in the RCA territory. Can you please do a cath? I bring the patient in, and guess what? I get hit by a wall because now there is no stenosis. I cannot put a stent. My fellows are asking me, oh, we want to put a stent. We need to graduate. There's no stent. So now what? That's when I go and dig for CFR and index of microvascular resistance or spasm to better understand why the patient had symptoms of angina, the documentation of ischemia on a stress test, and they have no blockages. That's when we come to play. 2 ways to do it. Simply, if there are any echocardiographers in the crowd, there's a wire. We put down the LAD, for example, and then we check the coronary flow. And it's very simple. You coronary flow, you have Doppler signal, and then you track it just like you're measuring VTI across the LVOT, and that's you measure VTI across the aortic valve, and you get the aortic valve area. Same thing here. You check the stroke volume in each beat down the LAD, and then you multiply that by the heart rate, you get the coronary flow. The problem is this technology is discontinued in the US, but it's coming back in the next couple of years. It's called the Doppler wire. It's a wire with an ultrasound crystal on it that will measure Doppler. We don't have it. What we have now, we have a wire that simulates exactly how the right heart cath works, which is measuring the flow using thermodilution, which means if I know the temperature of the blood and I know the temperature of a fluid, when I inject that fluid through a bloodstream into a sensor, I could detect the change in temperature, and that change in the temperature over time, I have the volume of how much I injected, I have the time it took from point A to point B to switch the temperature, I could tell you the flow. And that's how we did right heart cath, cardiac outputs in a cath lab, in an ICU for years since the consumption of Swan Ganz catheters. It is very simple. You inject 10 cc in a PA catheter. You measure the time it takes for the 10 cc to change the temperature between the right atrium to the PA, and you get your cardiac output. Same thing here, but now I'm doing this thermodilution or the temperature change down an LAD to understand the coronary flow. And this is how I do it in the lab. It is literally the same catheter as I use for any angiogram I'm doing. And all I'm doing here, I have a reservoir of room temperature saline, which is colder than the blood, obviously. And then I will inject down the LAD and check the temperature. Then I measure the time it takes for the temperature to change, the saline to change the temperature, and I will get resting time. And then I induce hyperemia. Remember, hyperemia is exercise. So I want to know what's the flow at rest based on time, and what is the flow at exercise or hyperemia. And that time would be my flow, a surrogate for flow. And a normal CFR value should be above 2.5. Simple. That means I could augment by at least double, if not double and a half. And when I do this, I'm done. Where is the problem? There is no normal value for coronary flow reserve, because if you take Michael Jordan coronary flow at rest, is certainly more than my coronary flow. And then when Michael Jordan is dunking, is climbing to have a slam dunk, guess what? He can augment by 10 times probably. I don't know. Those athletes, same thing with runners, same thing with Simone Biles. Those patients, when they do athletes, when they do somersaults, their flow is different than my flow, different than your flow. So I cannot define a normal value of how much flow you need. I don't know. But I know I need to at least double it when I exercise. The index of microvascular resistance is very specific for the actual circulation, microcirculation resistance. And that's where the money is. Because if that resistance is high and your blood is getting to the capillaries, but it's not participating in gas exchange, you will have chest pain. And the normal value is anything below 25. Why this is important? Because again, I have an actual value, irrespective of what flow, what's happening. I am looking at the isolated resistance in the microcirculation. Any questions so far? I hope. Dr. Bogle, can you screen the chat?
Nothing
yes.
in the chat.
Good. Perfect. So the second thing I do to make sure that there is no spasm, I do something called acetylcholine challenge to look for which patient have spasm. A normal patient, a normal human being, should vasodilate to acetylcholine, not vasoconstrict. So if a patient comes to the lab having chest pain and I give them acetylcholine and they collapse the coronary arteries into spasm, guess what? Diagnosis is made. You have vascular spasm. You have coronary spasm. You need treatment for that. Now, you can ask me, well, hold on. You're too detailed. This is interventional. Is this in the guidelines? If I am in the office, I'm seeing someone with chest pain, and I'm sending them to Bogle, what's going to happen? Is it in the guideline for him to do this? In 2019, ESC guidelines said, if you send someone to the cath lab and you cannot find, because they have persistent symptoms, they have chest pain, but their coronary arteries are either normal or they have moderate stenosis, something that does not need stent, it's reasonable to pursue what Hashim just told you, to measure the CFR and to measure the IMR, the index of microvascular resistance. And this is the workflow they suggested in 2020. They said, you are a cardiologist, you have a patient with chest pain, you evaluated the patient, history, echo, do whatever. Doesn't you don't change your practice. Then you decided to do a non-invasive evaluation, and you did stress test, CT angiogram, whatever. You decided that the patient needs a cath. In the cath, if you don't find any problems, you need to measure your CFR, IMR, and you need to do vasoreactivity testing with acetylcholine to understand why your patient is having chest pain. Then some of my American friends said, you know what? That's European. We're different. We're much better than they are. We need our own guidelines. And here we go. 2 years after 2019, 2021, we get our guidelines. And these guidelines was not interventional guidelines. If you look at who participated, there is no interventional society here. It's the American Heart Association, it's the American College of Cardiology, it's the American Society of Echocardiography, chest, that's pulmonology, those emergency medicine, those CT scanners, those cardiac MR, people who have nothing to do with cath. But do you know what they suffer? They suffer from patients coming back to them saying, you know what? You did everything. You sent me to cath, but you still didn't give me an answer. For that reason, they sat together and they said, we need to find an answer for those patients who are frustrated because they don't get an answer, and they're frustrating to us because we don't know what to do else. So they said it is reasonable to consider invasive coronary function testing, from what I just explained, to assess for microvascular dysfunction as an explanation for chest pain. Then the world flipped upside down, because 2024, as of 2 weeks ago, the same European Society elevated from 2A, this is the exact same paragraph that I showed you earlier. Now they said, no, let's combine all these two and give it a class 1 recommendation. It's not reasonable. It's not up to you to decide. If you have a patient who have persistent symptom despite medical treatment, despite a cath, you did every single possible. They have horrible quality of life. They're shopping in emergency rooms. They're going everywhere. You are obligated to understand why they have chest pain by assessing their coronary function test using invasive technologies. So now the paradigm is shifted, and I anticipate that the US guidelines will follow the European very soon. Now, okay, it's in the guidelines. Do my patient die, or should they just go? Like, who cares? They come to me, I don't solve the problem. They can go solve the problem at University of Virginia. I don't know. Let them go to Carilion. They go anywhere they like. I'm done with them. But does this disease a problem to them? This is the prognosis. We know that if you have a problem with FFR, which means if you have an epicardial disease, you do poorly. That's why we put stents. That's why we send patients to CABG. We also know that if you have a low augmentation powers, if your CFR is low for any reason, I don't care why. It could be lack of exercise, could be obesity. It doesn't matter to me. The fact that you cannot augment means you're not going to live longer. Done. So having low CFR is no good. Having epicardial disease, coronary artery disease is no good. Very well established facts. Where is the problem? The problem is if you cannot augment because you have high microvascular resistance, you get a D grade. D is right before F. You're failing your exam here because those patients, they do the worst. If you cannot augment your flow because of high resistance in your microcirculation, you do very poorly. Recent data from a few years ago published in JACC Intervention. Now you're going to say, okay, what is this IMR? Is this CFR or IMR? Because if it's CFR causes prognosis, why do I need to do IMR? Well, this is the problem. If you have high IMR, if you have high index of resistance, you will have more events, and as you go a year after another. Look at this. High IMR is the red. Patients really do poorly, and it doesn't stop. It continues to do poorly. As you age, the resistance can affect you negatively. Then you said, okay, we got this. Stop. We're done. It's too late. We want to go home. You talk too much. Where is the problem? You told us it's very easy. Bogle can't do it. Hashem can't do it. Anyone can do it. And then we understood it's bad prognosis, and we understand it's in the guidelines. How is this going to change my management? Like, what are you going to tell me differently that I don't know? Yeah, they have microvascular dysfunction. I'm going to give them medications anyways. Well, this is a different trial than from all the trials we know. It's called the Cormica trial. Cormica trial was a very simple trial. Took 150 patients. Took those 150 patients, all have chest pain, all have abnormal stress tests, all needed cath. Put them on the table. We cath them. We did coronary function testing on all of them. The 151 patients, they all get tested by Bogle and Hashem. Half of them, we told them, no blockages, go. I didn't tell them what they have. I knew what they have, but I did not share it with the patient, nor with the referring cardiologist. I told them what every single cardiologist in the area will tell them. No blockages. So what's happening with me? I don't know. Go to your cardiologist. He'll deal with it, or she'll deal with it. Done. The other cohort was actually told what we found. We told them, listen, we didn't find blockages. We found microvascular dysfunction. When we followed those patients over 6 months and 12 months, this is what we found. Just by giving the diagnosis and telling those patients what they are suffering from, we were able to have those patients to perceive angina with less severity. They're the same human beings. I did not do anything. I just told them, guess what? Your chest pain is not, you're not crazy. It's actually in the microcirculation. They start feeling less severe angina. They start perceiving themselves with less illness. They're not dragging, missing days of work, visiting emergency rooms because they're feeling sick. Their quality of life got much better. Their satisfaction to drugs got better because it's a normal human being nature. I cannot go to an oncologist and the oncologist tell me, you know what? You have a nodule. You might have cancer. Let me start chemotherapy. How many of your patients will start chemotherapy? 0. People want to know what they have. I want to know what diagnosis are you giving me for you to give me nitroglycerin, beta blockers, metoprolol, try some amlodipine. Don't take amlodipine. Go up on isosorbide. Oh, you have headache? Cut it down. Take more of this, more of that. But if I didn't give you a diagnosis, patients will look at me and say, like, you know what? I'm not going to carry a Walgreens or a CVS in my pocket just because you don't know what are you treating. So patients do seek diagnosis. Tested in this trial that giving a diagnosis is very important. This is the treatment now that was recommended by the Cormica trial as well. First of all, you have chest pain and you have ischemia on stress test. You're going to come, I'm going to tell you, watch what you eat, exercise, manage your weight, just like what Dr. Shah told us. Stop smoking if you're smoking, and do some yoga. Okay? Well, guess what? The patients are doing this already, but they're still having chest pain. Then you have diabetes, hyperlipidemia, hypertension. Manage those. You're done. Guess what? They're still having pain. This is where the management is different. If you look at patients who were diagnosed with microvascular angina, I'm going to ask a question and think about it for 10 seconds. What's missing of this treatment algorithm or recommendation for patients with coronary microvascular dysfunction, which means they have low CFR, cannot augment, high IMR? What's missing as a chest pain treatment? You thought about it? Here we go. There's no nitro. What? There is no nitroglycerin and the patient's having chest pain? How many patients do you think come to a cardiology office having angina, get prescribed nitroglycerin? All of them. Because this is what we have. You have chest pain, you need nitro. But guess what? If you have microvascular dysfunction specifically, nitroglycerin does not work on endothelin-independent receptors in the capillaries. Nitroglycerin enhances your nitric oxide at a cellular level. Nitric oxide is endothelin-dependent compound or a chemical that requires endothelial muscle or endothelial lining. That's why if you have microvascular dysfunction and you only have a problem with the capillaries, there is no endothelin-dependent receptors, nitro doesn't work. You need beta blockers, calcium channel blockers. Now, if I gave the diagnosis of vasospastic angina, normal arteries, but each time I give acetylcholine, they have spasm, what is missing here? Beta blocker. What? You have chest pain and you don't give beta blocker, but beta blocker may, slow down the heart, increases diastole, and when you have diastole, because the heart is slow, you work more efficiently, and we know the coronary flow happens in diastole. So beta, you want to tell me that a patient with chest pain, coronary artery disease, and you're not going to give beta blockers? Well, yeah, no, hold on, because that patient have vasospastic angina, and we know from COPD, from airway disease, that beta blockers could actually cause bronchospasm. For that same reason, they could enhance or they could affect vasospasm as well. No beta blocker based on vasospastic angina diagnosis. No nitrate if I gave the patient a diagnosis of CMD or microvascular dysfunction. And that's where medicine now is a bit more targeted. It's not chest pain, go to CVS, take isosorbide, headache, dizziness. You cannot take Viagra. You cannot have Cialis. Woman hates metoprolol, causes hirsutism, causes libido, causes gain weight, GI upset. We know these side effects. They happen. Patients don't want to take pills, especially if we are, as physicians, know that this pill does not work in that specific subset of patients. So let's go back to our case so I can conclude in a timely fashion in the next 5 minutes. Back to our case. I did RFR and everything was normal. I did FFR and every single thing was normal. But then I checked her for microvascular dysfunction. Guess what I found? I found the CFR of 2.5 right on the border of abnormal. But remember, CFR is not pathognomonic for microvascular dysfunction. What is more pathognomonic? What is more specific is the index of microvascular resistance. And to remind everyone, anything above or equal to 25 is abnormal. IMR value should be 25 and less. Guess what her index of microvascular resistance was? 39. We diagnosed this patient with coronary microvascular dysfunction. And the treatment simply is I gave the diagnosis. She was reassured that she's not crazy. Her husband believed her. Her kids believed her. The neighbors who walked the dog with her believed her that she is not nuts. Oh, she is, Mrs. Hashim is crazy. Pain, you get cath 4 times. What else do you need? You get referred to half of the country. What else do you need? Well, guess what? She needed the right diagnosis. Now, I switched her treatment. I took the nitrate out. I put small dose of non-selective beta blocker and a low dose of amlodipine. And I controlled her blood pressure, controlled her LDL, her cholesterol, and she never came back. Now, if you don't believe in this condition, by now, the CDC, as of October 1st, 2023, I led the force in front of CDC to recognize this condition as a disease because it was not recognized. It was called syndrome X. It was called prinzmetal angina. It was called angina of unspecified reason. There's so many names. Now the CDC agreed based on the data that we have that this disease has to be coded for. This is not billing. This is not making money. This is if you send a patient to Dr. Bogle and he makes the diagnosis, he needs to write down ICD-10 code of chronic coronary microvascular dysfunction of I-25.85. This way, the CDC could track those patients, could see what's the incidence, what's the prognosis, how much they cost the healthcare system before the diagnosis appeared. This is a way for CDC. And if you know what ICD stands for, it's an international coding of diagnoses. International. So the whole world follows suit when the CDC says there is a disease, and now this condition is being tracked all over the country, all over the world. And with that, I'll say thank you, and I'll take any questions.
Oh, thank you, Dr. Hashim. It was a great presentation. Actually, I do have questions for you, but thanks. That's a great work getting the ICD diagnosis for microvascular disease. So we just got the CMD tool here. It's like we just got like a few months back, and we are trying to be part of CMDR registry at MedStar with you being the PI. So the most important question, like I've talked to a few physicians, including cardiologists, intervention cardiologists, so very important. The most important thing, is like, when you tell them like about the patients, if they have like microvascular disease or if they have recurrent chest pain, because we don't have like this technology in our nearby hospitals, at least 100 miles, I think. So most of like few of them do say like including few physicians that what do you do after that you start these medications, so we can start it without it. So I think I want to ask your opinion on like you get a lot of referrals, so what is your take on like talking to other cardiologists, how
Sure.
to convince them, and also like nearby physicians? So
Perfect. So when I first did this, we got this we built the program August of 2021. We've been doing this. The registry now carries close to 400 patients. Now, obviously, we're a tertiary care center. We're big. We have a lot of research, as you know. We have a lot of IRB for many things. I do microvascular assessment in patients with Takotsubo, with patients with amyloidosis, with patients with heart transplant, patients with receiving chemotherapy, cardiotoxic chemotherapy. So there's so many things that we're understanding now. The number one push, nobody cares about the research now. If I have a patient in an office with 20 other patients to be seen, I understand where other physicians would come to me and say, you know what? If you give me the diagnosis, how am I going to treat it? Beta blockers? Guess what? I'm going to give beta blockers anyways. Well, it's up to you. It's up to the philosophy of the treating physician. Are you a try and error kind of guy? Or are you someone who wants to go by guidelines, who wants to know exactly what they're treating, because chemicals comes with side effects, drugs comes with side effects. It's the same. I cannot assume everyone has hyperlipidemia and give them statin. Guess what? We need to do lipid panel. We need to adjust the statin. If they don't respond, we do PCSK9. I'm referring to Dr. Shah approach. You need particle size at least once in your lifetime. So we look everywhere to be very specific in what we do. And when it comes to chest pain, that leads to so many admissions, so many non-invasive testing. And now we want to try and error. Well, guess what? Try and error. But those patients, there is a big population who leave your practice, come to my practice, leave my practice, goes to your practice, searching for an answer. They land in your emergency room, you admit them, 2 negative troponins, because guess what? Bogle just cath you in March. What do you want me to do? 2 troponin, nurse practitioner sees them in the morning, discharge them from observation, no answer. Now what? You're going to increase the beta blocker or the nitrate? Which one you want to do? So that argument can easily be pushed back at them, because you need to know a diagnosis. This is my passion. I hope you're sensing it. I cannot take that argument. What are you going to do differently? Just try medications. Well, guess what? Then keep trying medication, because we gave Mona for patients with heart attack and it worked when we put patients for 4 weeks after STEMI. Do you know what we do now after STEMI? Cardiac rehab. What are you going to say to that? We stopped giving morphine. So science change, medicine change. 50% what I learned in med school 24 years ago is now malpractice. 50% malpractice. Not even I'm not doing it. If I do it, I could go to jail. So you need the diagnosis. You need to be specific. That's how I would push. And I hope some of you are referring on the phone, and I'll debate anyone that making a diagnosis, it is so instrumental in medicine, especially when the treatment is different. It's not a try and error anymore.
Yeah, I think that's a very good way to put it in, because I think still we have like a lot of physicians who don't believe in it. That's what I noticed when we got this technology here. I mean, we are not like, we are like small hospitals. So obviously, yeah, we have done maybe like 7-8 cases so far. But that's what we have noticed, like particularly me, because I talked to a few of the cardiologists. But anyhow, the second question I have is, I have a patient. This is a real-time scenario. She's like young. She's a nurse, and she said like she had microvascular disease in the past, but she doesn't know if ever diagnoses were ever made. It was like she had a cat like 2018, but she has constant chest pains. And so I was like, oh, now we have a technology, we can diagnose you, here you go. So we ordered a heart cath and the insurance declines,
Yes.
So the next step is I ordered a stress test, and stress test is again decline because she had a heart cath a few years back, it was normal. So she does have rheumatoid arthritis. So we said like we will do the like then I do peer to peer, and finally we got this test approval because her chest pain is like really worse.
True.
And now we did the stress test is absolutely normal.
Yes.
So this is like real time patients I have in my clinic,
I
So
agree 100%.
yeah. So
I have
now
those patients. Yeah. Now
yeah.
what?
So now I already put her on like Corag and Loripine. Her chest pain is better, but I cannot cath her, So with normal, because our guideline says at least mild ischemia on the stress test. So what's your approach on these kind of patients?
Excellent. So if you look at the European guidelines I just show you, they do not talk about evidence of ischemia anymore. It's ANOCA, which means angina with no obstructive coronary disease, or ischemia. They used very specific terminology. Patient with persistent symptoms, because they wanted to defy this problem that we have in the US, that you pick a peer-to-peer and the other peer, unfortunately, is a retired orthopedic surgeon discussing, going through a checklist, looking for approvals. This is a major problem here to be fixed, hopefully. That patient like this, if I'm going to the peer-to-peer fight, you know what I order? PET CT, PET stress, even if she has to drive for 60 miles away. Because even if she has no ischemia on the PET stress, at least you get that CFR from it. And if you know her, yes, she might have, she doesn't have infarctive cardiomyopathy, I hope. I hope she doesn't have LVH. So if your CFR is low and your cath was normal, then at least you are 5 steps closer to making the diagnosis of microvascular dysfunction. Those patients, I don't order regular stress test anymore. If I'm going to battle with insurance, I will go the PET CT stress battle, because at least I can get CFR out of it. That's my own recommendation now. I hope when the guidelines come, I will take the guidelines and stick it to the peer-to-peer and say, you know what? You want to reject the guidelines? Okay, your license, not my license. Because the guidelines is not, in 2024, the guidelines says persistent symptoms, not evidence of ischemia, because we acknowledge patient with ANOCA, angina with an A as an apple, no obstructive coronary arteries, not necessarily INOCA or INOCA.
Okay.
Dr. Bogle, there's a question in the chat.
Yes.
Okay, let me take that.
Yeah, the writer says, I noticed there is an ICD code for MI with capital CMD. When would you decide to perform coronary flow after a PCI question?
Oh, perfect. Great question. I spoke about this topic is require grand rounds level of presentations. I need probably 3 hours to cover every single thing. But I'll tell you what I know. Many of you, if you work in a cath lab or an emergency room or a cardiac ward, you know on a Friday you get a patient with NSTEMI and you debate marination with heparin over the weekend until Monday, or skip baseball practice and dinner with my family in Red Lobster and go do the cath. And we end up bringing them to cath, and my nurses look at me, oh my God, don't tell me you brought the normal coronaries. And I will do a cath. There is NSTEMI. There is myocardial infarction based on troponin rise and EKG abnormality and wall motion on echo. And you bring those patients and you find nothing. Those patients, I will perform. If I don't see a blockage, I will do 2 things. I will do something called OCT, optical coherent tomography, which is an intravascular imaging modality that will tell me an entity called plaque erosion. No plaque rupture the way we know it, because if it's a plaque rupture, It's a clot, it's a stenosis, you put a stent, life is good. Done. There's certain patients where the vulnerable plaque is pushing, but it doesn't pop open like a volcano. Those patients still present as NSTEMIs. I will do OCT, and OCT is the only modality, only technology in the US and in the world that could detect vulnerable plaque in 2024. And I will do microvascular assessment on those patients. So that's to address patients with MI-NOCA, MI with no obstructive coronary arteries. Now, the patient I did, she had a stent. To answer the second part, when do you decide to perform after PCI? PCI now is different. We know, I wish I could show the slide again, but I'll tell you, there is a big cohort of patients with microvascular occlusion and microvascular dysfunction because of your intervention. If I'm doing a PCI on a patient with clot or lipid, and that lipid debris travels down, you will have increased microvascular resistance. That's very normal. That's the essence of the disease. And we know the higher IMR in a STEMI or an NSTEMI, the worse the prognosis. So now, if I just put a stent in a Prox LAD, or Bogle just put a stent in a Prox LAD because of an NSTEMI, there's no value of checking IMR now. Guess what? It's elevated. Now, when do you do it? Based on trials on LV recovery and infarct size assessment, we know it takes about 6 to 8 weeks for you to have whatever stent myocardium recovered, whatever hibernating myocardium recovered. So if you have a patient with CAD, you did PCI, don't do IMR immediately. If they persist to have chest pain, despite the fact your stent is good, and you bring them back to check your stent, do microvascular dysfunction within 8 weeks. That should reflect if there is an iatrogenic embolization of plaque down the circulation, that has recovered by now, and you should have a diagnosis. Because 20 to 40% of patients in the US have stents, they could have microvascular disease concomitantly. So I will do that. If I did the PCI, I would wait 8 weeks.
Yeah, that's good. That's good, Dr. Hashim. One more question, Dr. Hashim, regarding the OCT of vulnerable plaque. We don't have this technology. So if I get a patient with MI-NOCA or Takotsubo, if it is during the day, we try to do the CMD. So what do you recommend us, like the small centers? I know you guys are part of HARP trial.
Sure.
So would you still recommend us doing, like, sending the patient for MRI? So what's your take on this kind of patient? Because their openings are like 4,000 or 5,000, and we don't find anything. Yeah.
I have many cases. Maybe next week we'll present patients with acute coronary syndrome with no obstruction. Those patients, I believe the workflow in the next 5-10 years will be: you do a cath, you find nothing, you do CMD assessment, then you do imaging if you have OCT, and if you don't have OCT, I believe the modality that makes the diagnosis is cardiac MRI. The problem is when to do it. Most of the trials, and as you mentioned, the heart attack program, research program, HARP trial, which is an NIH-sponsored trial that we are part of at the hospital center, we decided as a consensus steering committee that a week you have to get a cardiac MRI within 7 days of the acute insult, because any findings of T2 edema, any findings of LGE, late gadolinium enhancements, would appear or would disappear after 1 week. So to nail the diagnosis, because myocarditis from COVID, you published on that, we published on that together. We know that COVID caused a lot of myocarditis. COVID vaccine caused myocarditis. We saw an uptick in young patients with myocarditis. So, and they have troponin and they have normal coronaries. MRI can make that diagnosis, but it has to be done within 1 week. Patients with a real infarct, a transient clot, clogged the vessel, dissolved on its own, or with the heparin you gave, with the Plavix you gave, or clopidogrel you gave, then you should see LGE. Patients have Takotsubo, they have edema, without anything else. So cardiac MR is the modality to make the diagnosis if you have nothing available in the cath lab, and has to be done within 1 week.
Okay, got you.
Dr. Thank you so much, Dr. Hashim. We're running out of time a little bit. We're past the hour, but both speakers, I don't know, I think Dr. Shah had to leave us, but these are superb presentations. Thank you so much. Dr. Bogle, thank you for your help in getting this organized. You are spot on correct that Dr. Hashim's the guy, and we're so happy to have him. Dr. Shah, there you are. I hope it's not raining too hard at Dr. Duke's right now. For everyone else on the call, thanks for being on the call. We had a record number of folks. We talked about a lot of good stuff. We hope you'll be back in 2 weeks to hear an update on melanoma, a really important type of cancer, because now there are new treatments. If you knew from the news in the year gone by about previous President Jimmy Carter had an unbelievably good experience, something we just didn't have years ago in managing that. So we hope you'll see you back. For everyone, thanks for being on the call. As we tell our residents, please be careful out there. That's even more appropriate with the hurricane coming. We hope you and your family are safe during that. So thank you so much. Have a great evening. Good night. Bye-bye.
Thank you. Thank you, everyone.
Thank you.